we defined it here is because if I asked all of you what self-care meant to you, you'd probably have all completely different answers. So we did this study because we wanted to find out what people who were frontline workers felt like was their self-care. And we used an instrument that measured self-care agency, which means the ability to meet and recognize your needs and then assess the available resources and then to act to achieve a certain type of goal that you have for yourself regarding taking care of yourself. And then as we were going through this process, we didn't know that we were going to start to use the term self-care literacy, which takes this idea of self-care and puts it into the literacy realm, meaning now we're talking about not just knowing or being motivated, but having those competencies to promote health, to prevent disease and maintain health with or without the support of a provider. Now that is the World Health Organization's definition. And we know that the World Health Organization tends to have very vision-oriented definitions that aren't necessarily functional. So if you looked at this, you wouldn't know how to really put it in action. So one of the things that we're doing with a study is also taking all of our data and we're going to create a functional definition of self-literacy, self-care literacy that can be used by different people, professions, for example, EMS, in order for them to understand not only how to take care of themselves, but how to get the resources they need, how to shift their environment and work with their leadership to create that change. So that's why it was so important for us to explain what self-care literacy was. And it's definitely emerging and we haven't completely defined it yet, but we've started to. Let's go to the next slide. So when I was talking about this growing out of COVID-19, we had done 2 previous studies completely online. One of them was about COVID-19 and physical activity in the general population. And another one was about quality of life while working from home. We had huge responses to both of those studies. And then we realized that we really wanted to know what was also going on, not only with the general population, but with the frontline workers. So this was done at the post-peak of COVID-19, September 22 to January 23. Now, many people may have felt like we were out of the pandemic at that point, but the healthcare community and the frontline community certainly was not. We collected the data via online system. It's like SurveyMonkey, but it's called Qualtrics. And then we recruited via LinkedIn mostly. And they were closed groups. And that's actually how I got connected with Unity bands. And we used something called snowball sampling, which means when somebody participated in our study, we asked them to share the link with somebody that they knew also qualified to participate. And that's why when we shared it with certain professionals who are thought leaders in their professions, we got bigger numbers in those areas. And we're starting to see some of the other areas as Vanessa and I and Laura continue to analyze the data. Some other big response areas, which are not included in this study, we had, I think it was close to 70 public health workers that responded. Now they don't go into, we use the BLS definition of healthcare jobs. So they didn't go into that group. So I think on the next slide, you'll see who did, oh, I'm sorry. It'll be the next slide. That's all right. Go ahead. No. Go back. Go to the instrument. Okay, good. Thank you. So this was what we used to actually understand what self-care agency is, and it's an instrument. So that means that it has items that people respond to on a Likert scale, which is, there are those scales that you see where they say strongly agree to strongly disagree. So this one was very quantitative. And it was called the Self-Care Agency Scale Revised. And what it was looking at was how people took care of themselves regarding how much power they felt they had over their situation to take care of themselves. So there was the having power items. And an example was, I can usually take care of my health problems myself. So that was one of the subscales and groups of items that we used. The other one was developing power for self-care, meaning I'm learning how to take better care of my health. And then the other 4 items of this instrument that we used, self-care instrument, was lacking power for self-care. So that was, I find it difficult to take care of my health problems. So later you'll see our results, and all of this information would be represented in numbers. So the averages of responses overall to how much self-care they had, which is all the answers to the instrument. And then by these groups, having power, developing power, and lacking power. And then on the next slide, I had said before, total frontline workers, we had 586 participate, but you'll see the healthcare was defined by the Bureau of Labor Statistics, healthcare jobs, and that was 269. And Vanessa's going to speak to this a little bit.
Thanks, Michelle. So like Michelle mentioned, this was derived from the U.S. Bureau of Labor Statistics list of frontline workers. And so healthcare was a subset of the total frontline workers that were listed and that participated in our study. And so the largest number of responses that we received from the total of the healthcare workers was from the EMS group, which we received 106 participants that decided they wanted to participate in the study, and they completed the study. And so this is a main reason why we initiated our research even further with the EMS group, was because they were so plentiful. They responded in such a large mass. We also then had other healthcare workers participate in the survey. RNs, followed by nurse anesthetists, nurse midwives, nurse practitioners, physician assistants, and physicians and surgeons. There are also other healthcare workers that did respond to the survey, but these were the ones that we received the largest responses from. And I'm going to pass it to Michelle.
Thank you. And as I mentioned, we had other disciplines that responded as well. So we have big groups of unanalyzed data that we will be looking at in the future. And the EMS was a good place for us to start because, like, we have the largest group, but we also have Scott on as a consultant to help us understand the data better. So there's over 269,000 EMS practitioners with a median income of around $44,000, $45,000. And what we know from previous research is that the well-being and the wellness of this group could be improved. And while there isn't a lot of research, most of the research that has been done has shown that there's some problems with the EMS group, which first of all being, we've seen consistently in the literature, physical activity guidelines, them not meeting them. And then the majority being obese in a 2021 study. We've seen elevated blood pressure, higher alcohol consumption, which was definitely reflected in our qualitative responses, which we'll talk about later. Work conditions contributing to mental health problems and well-being, increasing the risk for developing PTSD, depression, anxiety. And it's completely understandable working in the emergency situation all the time, and then add on COVID-19, and you can imagine the amount of stress that there was for this community. And Scott will speak at the end a little bit more. We want to stay till to the 30 minutes. And we know that we could talk about this for hours, which we've done previously on other presentations where we stayed on an extra half an hour. So let's go to the next slide. So we had a population that's probably pretty reflective of the, not representative, but and definitely not generalizable to all the EMS groups, but we had 91 complete the quantitative part where they answered all the questions to what I showed you, which was the self-care agency instrument. Mostly men, mostly white. We do have representation from different groups. And one of the really interesting things that most of them have a bachelor's degree, but when Laura and I were looking at this, we were pretty surprised to see that there were actually 4 that identified as being able to work from home. But what is interesting here, and I'll explain why this happened, only 61 completed the demographic questions, because the way that we designed this was we put questions at the beginning and then making sure that the people were qualified to participate. And then we asked them to do the instrument, the quantitative part, and then we actually asked them to answer 10 qualitative, which means open-ended, where they wrote down or they typed down their responses. And we, out of respect for them, based on confidentiality and knowing that they work in a small field, we put the demographics at the end. And that's why you see those differences. And we'll explain that even further later. So this is really Laura's expertise, but I wanted to explain what this means. Basically, in layman's terms, this means what we look at psychometric properties of the responses to make sure that we can say that this instrument is usable in this population. And we run tests in order to make sure that if there's validity and reliability, which basically means, is this instrument appropriate to use with this group in the healthcare community? We tested it. And what we found overall is that those 15 items that I gave you some examples of were good for the mostly, with the exception of developing power, which was 5 items, and they had acceptable reliability at the 0.70, but that's really barely, and we really like to see it at least in the 0.80s or higher. Anything else you want to add about that, Laura? I always ask her if I did a good job of that.
I think you did do a good job. You're getting better. But I think that covers it pretty well. The only thing I'll probably add is that when you look at the reliability numbers, a lot of times you can kind of play around with dropping some of the items to see if going down to 5 items on a certain subscale or just losing items from the overall instrument will improve the reliability. And we looked at that with those items, and we didn't find that dropping anything would have made any of those subscales or the overall instrument better. So that's why we kept everything, even though, as Michelle said, that developing power subscale was not quite where we wanted it, but there wasn't a way to make it better. So we went with it and feel like the instrument, it does measure what it's supposed to measure, and it's okay to use in this population, even if it isn't quite ideal.
Right. And I think when we looked at the literature, everyone else had around the same numbers. So we wanted to make it comparable to the literature because it was important for us to understand what this means, what our results mean. And then we would have to compare it to previous literature. So we made those decisions to leave it all as is. So let's go to this next slide. Laura did all of this. She did the descriptive statistical analysis. So that N of 61 was looking at the demographics of the participants. So they were the ones that chose to stay all the way to the end, including completing the demographics. And then also doing descriptive analysis of the responses of the self-care agency scores and the 3 subscales. And we had 91 participants that completed that. So let's go to the next slide. Okay, so these were our results. And they really don't mean a lot because you can't really compare them, but the mean of the total response to the whole scale was 50. And then you'll see having power, developing power, and lacking power, 21.5, 19, and 10. The overall maximum score for this version, because it's the revised version, there are other studies that use the self-care agency scale, and they revised it to make it stronger regarding those psychometric properties. So we're only looking at studies that use the self-care agency revised, where there was a maximum score of 75 points. Okay, so here's the big reveal on the next slide. Our group is the lowest self-care out of all the published literature. So the EMS are lower than postmenopausal women who had a 62.27, older adults in China with or without comorbidities, people with multiple sclerosis. Now, we also looked at the healthcare participants as a whole who were not EMS in our study, and that group was higher at 53.1. But interesting that another study looking at nursing students was the second lowest compared to our EMS group with a 52.69. Now, there are other studies that use this instrument, but they use it in a different way, where they're looking at associations with other concurrent things, like they'll look at self-care and depression. So they aren't reporting, while they have to run the means to know what the scores are for the participants, they're not necessarily reporting the information exactly as you see here, where they report the means for the total and then the subscales. So the instrument's been used in many other studies, and there's been a lot of different studies in different languages, and they've been validated regarding, again, the psychometric properties. But not a lot are actually reporting the most usable information, which is, what does self-care agency really look like in these populations? So we thought it was really important for us to share this descriptive data so people really understand what it means. This group, compared to, of course, and they're in other countries, different populations, have a low self-care agency. And that's what we can deduct from that. So if we go to the next slide, when we first ran the statistics and we looked at it, we didn't really want to say this group has low self-care because we didn't really know the whole story. So later, Vanessa and I spent some hours together, and we took the responses to the open-ended questions that were completed by 70 of the participants. So 91 completed the instrument, and then 70 of them answered 10 questions. And I'm just blown away by the fact that they wrote so much. So Vanessa and I went through their responses, and something that we found to be really interesting is that we're using something called Atlas, which is a qualitative software. And just in the last couple of years, they're starting to make AI available. And there's something called an AI summary, which is very similar if you've ever gone on to Amazon and you've looked at the product summaries at the top, the AI summaries, to see what they said. That's exactly what we did with our qualitative responses, because it would be really challenging to code the answers to the 10 questions individually. We will end up going back and doing that, but we wanted to really understand from these AI summaries where the people were regarding having power, developing power, and lacking power. So we could truly understand that if you just looked at the means, it would make you think that everyone in the EMS community was not practicing self-care. That is not true. As you can see, 25 of our participants, when we went through and looked at their comments and coded them as either having power, developing power, or lacking power, this group, it wasn't that they didn't face challenges. They faced challenges and demands on their financial conditions. But what they did was they went out and found support in relationships. They went and got medical care. They managed their emotional health, a lot of them through therapy. And then they also talked about engaging in enjoyable activities. So we had 25 that were really strong at practicing self-care. And I was impressed when I was reading. We both were impressed. We're like, wow, they're doing such a great job. And then we got into the developing power group, 22. They were prioritizing mental and physical wellness, and they were using exercise, counseling, balanced diet, but then ultimately found it difficult to take care of themselves due to exhaustion, the increased workload, and chronic anxiety. So they were trying and they were developing the skills, but they weren't having power in that process. And then the lacking power group worked, 23 of them, working as an EMT paramedic in a high demand area during the pandemic has led to exhausting work hours, irregular sleep patterns, unhealthy eating habits, and limited time for self-care activities like physical exercise. Lack of time for meal planning, sleep, work-life balance, and energy has made it difficult and challenging to prioritize self-care. So these were actually the words of participants that answered this question. We gave you examples, exactly what they said, and regarding the AI summaries. And so what if you look at it, 25, approximately half of them that answered this had power, and then 45 of the respondents were developing or lacking power. So that really helps us understand that it's not that no one in the EMS community was practicing taking care of themselves. They were just on a continuum from those that were experienced with it and were able to do it to those that were trying to do it and having real challenges and not being successful. And then those that completely felt like they had no control over the situation or any control over their self-care. So those 70 helps us better understand what the results were previously from the instrument. And we're so glad that we did both the quantitative and qualitative, and this would be called mixed methods, because it really helps us to hear the story and understand the story of the EMS from their perspective. We could have just done, and many do just the quantitative part, but we wouldn't have this complex understanding of what was really going on with this group. And we still don't know everything, right? But it really gave us a snapshot of during the time what they were feeling. Let's go to the next slide. So I wanted to show you, we really pride ourselves on doing participant-centered research. And this is different. We use different language than a majority of the research community, really focused on the participants and making them comfortable. And what we found is that when you respect the person that's participating in your studies, it really pays off. So in this EMS group, I had talked before about how we designed this purposefully. We had the pre-qualifying demographics because we never want to waste people's time. So we want to know very early on if you're going to be able to participate and you will have consent, right? The informed consent. But if we ask these questions early on, we can make sure that we're not spending valuable time when the person doesn't qualify to participate. So 91 of the EMS answered 4 to 6 questions because there were some questions where you could be in 2 different professions. So for example, they could have been EMS and they could have been working in higher education. So that varied how many pre-qualifiers they had. And then they completed the actual instrument that was about the self-care agency, 91, and a total of 15 items. The qualitative, 70 of them completed 10, which blew me away. They stayed on. But what we were meaning by having respect for our participants regarding the demographics, you can see that people stuck it all the way through, but some of them didn't feel comfortable answering the demographic questions. And if we had put them at the beginning, we would have lost them. It's really important for people to respect the fact that some people aren't going to be comfortable sharing that information. And we're really happy that, 61 people did, but we also didn't want to put anybody in the position where they could be identified or feel uncomfortable with the answers that they were providing. So it was really important for us to highlight how successful that was, and that we really encourage people as a researcher to think about putting not the pre-qualifying questions like, are you 18 or older? That is a demographic question. We had to ask that at the beginning. But those questions about gender and race, sexuality at the end, because that gives people the opportunity to participate, but they don't have to share all that information. So the next slide. So what does this all mean? We know that the EMS community is aware of self-care, and they probably know how to do it, but their self-care agency is depending on their physical, their cognitive, and that psychosocial environment. So it has a lot to do with the situation, the leadership, the actual structure of their work. We want to make sure that we point out that it's not that we think that they don't have the skills or the knowledge, but that they probably didn't have the support. They probably didn't have the resources that they needed. And so that's why we want to think of self-care literacy as beyond just an individual's literacy, but this idea of the whole profession learning from what happened with COVID-19, and not just thinking of self-care, because that tends to be something that is put on the individual, but that it becomes a systematic idea, and that we start talking about, just like we talk about literacy in general, that we have to have the resources and the support in place in order for people to have self-care literacy. So obviously, this is preliminary, largely exploratory, not representative, not generalizable. We know we need to do future research, but I think based on what we found, we're really excited to continue this line of research because we think there's so much more to explore in this group. And we also think that we could explore it with a lot of other healthcare professionals. And we're really excited about doing the additional data analysis with what we already have. But I'm going to open this up to Scott just to make sure that this last slide is representing the EMS perspective, because he's so helpful with us understanding this data because he's lived it.
Sure. I think it definitely represents the EMS providers out there. I think it and honestly, the results to me weren't surprising. I've been in EMS. Even though my day job is in an office, I'm still a practicing field paramedic. I worked all through COVID. I was in the Tyvek suits. I was spraying bleach throughout the back of my ambulance after every call in the spring and summer of 2020 when we didn't know what it was and people were dying from it. So none of the data actually surprised me when they got it back, because it's really closely fit my lived experience in the profession. I do think the key point is it's not that they don't have the knowledge, they don't have the support, they're not given the agency to take care of themselves. One thing to remember about EMS providers, especially in metro or suburban areas, is they work very long shifts. I work almost every other weekend as a paramedic, and I do a 24-hour shift when I work. The hope is that I could sleep during that 24-hour shift. Being an old man, I tend to choose wisely where I work. But for the newer providers, the 20-year-olds who are out there, they're working in Boston while I'm working in Amherst, right? I'm working in a small town. They're working in the city. They don't get the breaks. They don't get the time to eat. So most of their food, unless they can get up early enough to prepare and bring made food with them to work, is whatever they can get at 7-Eleven or a fast food drive-through during their 16 or 18 or 24-hour shift. They get off of that shift with very little sleep, go home, fall asleep. There's no time for them to take care of themselves. And then usually they're off for a day and they're back on for another 24 if they're full-time workers. That tends to be how their job goes. Earlier, Michelle was talking about the BLS. The BLS clarification of or classification of EMS is a little skewed because they classify everybody in the same lump, which would be like classifying medical assistants and cardiac surgeons in the same group and trying to find median incomes and median education levels. Like the data is far too skewed. Paramedics go to school for at least a couple of years. EMTs go to school for a couple hundred hours. So there's a big delta in their pay, but the job is very similar. And during COVID, it opened up a lot of gaps. We have not recovered from it yet. I do not believe that this study was too late when the data was collected because we were, quote, through COVID already. We're not. As a profession, I can tell you that we are looking at anywhere between a 25 to a 30% provider shortage right now, pretty much everywhere across the country. If you're bored, Google ambulance service shut down due to staffing or funding. There's ambulance services shutting down all over the country, which is actually going to become another area of study because it's a huge access to care and equity of care problem, because there are now ambulance deserts in the country where if you call 911, you're not getting help. We never had this before COVID. There's a lot of burnout, a lot of the PTS that happened, people left the field and they haven't come back. So there's definitely more research in this that needs to be done, both in self-care and in EMS in general. A lot of the COVID research is just starting to be published in the literature for EMS specific stuff, but most of it is looking at provider shortages and funding reimbursement problems. But they're not getting to the core of the problem, in my personal opinion. It's all about the crews feeling taken care of, feeling like they're supported. Nothing worse than getting a slice of cold pizza and told to get back on the street. And that unfortunately is not abnormal.
Thank you, Scott. And that's
More that time than the last time.
so we have a lot of work to do regarding research. Who has any questions or comments? Hi, Jennifer. Oh, I can't hear you.
Can you hear me? Okay. Thank you so much for presenting this research. It's been really fascinating to follow along. I'm curious for the group that you found that they did have the power for self-care, if you collected any data, if they were already participating in some of those activities pre-COVID. So if they already had a relationship with a mental health professional or were already managing a chronic condition of some sort, that it wasn't necessarily new to the pandemic, but they were able to maintain consistency with an established plan of care that they already had.
That's a great question. And a lot of the things that I wake up in the middle of the night and I wonder about. So that's absolutely something that I'm like, I think Vanessa and I are going through and reading it. And there's definitely people that were continuing care that they had already established, and they were very self-directed. But there were also people who, through their journey through COVID, were struggling with something they never had encountered before, and were developing a new routine. So there was mentions of the changing their habits and like not having to commute as much, so they were able to do better things, or, and that was actually really better things for themselves. That was actually really interesting, because I think going through the people who were able to work from home, and a lot of healthcare providers were in the larger group, were definitely able to have more power in the process. So Jennifer, I wanted to really, I was thinking about this morning. What if we did this study again now, and would it be the same results because they're always under constant emergency and always in emergency situations? Or did that take it to the next level? So I appreciate that question, and I really do wonder, but we don't have the answer, because maybe if we had done it a year before, or we do it a year after, the results will be the same or completely different. We don't know, because they're always under that fight or flight. But Scott, I would like to do it. You don't think so? Both of them?
No, that was to Lewis's question that he posted in the chat. Yes, I would love to do it. I can also touch on that just from personal experience, Jennifer. I think for some people, COVID did push them to make changes. Michelle is the only person here who has seen me in real life, I think. She was my thesis advisor for my master's at Seton Hall many years ago. And I was 70 pounds heavier. I dropped the weight after COVID. I started in spring of 21, actually. Part of it was because I had a little hypertensive emergency, probably because I was working like a moron, constantly with an SCBA breathing apparatus on for months and months at a time. And I'm not a young guy. I'm 47 now. So I was doing the job of a 25-year-old and about 275 pounds. And I had a moment, and I needed to improve myself. So like if it wasn't for COVID, I guess I would think of it kind of like, alcoholics and addicts kind of have to hit rock bottom. My addiction was pizza, and not eating and not moving. And I had to hit that rock bottom phase. And I don't know that I would have hit it without a major medical event if it wasn't for what I went through with COVID. So it definitely pushed me.
I think those pivotal moments were reflected in some of the responses, and we're meeting tomorrow we're hoping to get the rest of the healthcare professionals analyzed as well, so we can understand that more. And then we realize that we'll be doing more data analysis using the self-care matrix, which will be able to start to understand the responses of the different professions and look at the professions' resources and what they mention and compare them to see what was it like for PAs, what was it like for the nurses, what was it like for the EMTs collectively. So we'll have a lot more understanding of this data in the next 6 months. And then we will definitely be publishing. We weren't sure that we would have an individual article on EMS, but we definitely will now. There's so much to unpack.
Okay. Last call from questions from the group. All right, nothing heard. So Michelle, anything else from your team before I wrap things up here?
I'll let any of the other our co-collaborators. I think Vanessa was frontline as a PA. Laura, were you frontline at the time, or?
No, I was teaching already. I had moved into that. So yeah.
So I think one of the things I would say is that we tried to get as many people involved in the study, interdisciplinary perspectives. And there's other people that have been involved too, and are working on different aspects of it. But I was really happy to bring this interdisciplinary, interprofessional team together and to talk to all of you, because it just seems like your mission is very related to what we're learning about. And so I think what we don't want to happen is to publish it and have it not get out to practice. So I'm hoping that as we publish it, we can work with people like Scott and leaders in the EMS community and the healthcare community in general, and really learn from the COVID-19 pandemic. And Vanessa, I asked her in our last session, has the PA, the physician's assistants community, debriefed on this or created learning? And what was your answer?
I think we're too busy working to debrief. Scott hit the nail on the head. It's just a lot that's being asked of us. But that's our field, right? That's our field. We are patient-centered. We are all about making sure that people are safe and getting the help that they need. And then ourselves, our families, they come second, because, and especially during COVID, and especially even now, 4 years later, we're still in crisis mode. Like Scott mentioned, we're still in doing overworking. We're still doing shifts longer than we need to. Sometimes it's required for us to take on more shifts than we're actually contracted for, because they need us. They need bodies. They need people there taking care of others. So like the qualitative research showed and the quantitative research showed, our responses demonstrate that self-care was hindered during this time. And we still need the support there. So I have to say, Scott, you really represented that in a way that hit home for me, and I'm sure for others. So thank you for highlighting everything that you did. And thank you, Michelle and Laura, for doing the work that you're doing on this.
If I never have to wear an N95 for 12 hours again, I'll be a very happy man.
I'm talking and not unmuting myself. Thank you so much. I really enjoyed this, and it was great to see all your faces. And we hope to work with you in the future.
Thank you very much. This was very informative. Really, really good. Thank you for your time and dedication.
I have to thank Scott and Vanessa and Laura, because I could not make this type of thing happen. And I feel like when I reach out to them with an idea, it's always a yes. So I really, really love that. And I really appreciate it. It's been a really, under stressful circumstances in a terrible situation, it's actually been an enjoyable collaboration.
And
Awesome, guys. Thank you. So for Dr. Diabundo, Rodriguez, Marinaro, and Lancaster, we really appreciate you all doing the work, but also sharing the preliminary results with the team here. This is the first time we've had this many guest speakers, so this is awesome, having 4 at one time. That being said, in the chat window, I included the link to our survey. We're interested in what you guys thought of this session, but also what topics should we talk about in the future. I will say this, when we analyze the results of the survey, it's not as comprehensive as the study that you heard tonight, but we still learn a lot from the findings from people that sit in on these sessions. I do want to share my screen for 1 second because I want to highlight a couple of dates that we have coming up here in the near future. So coming out of this weekend, we did have our benefit on the beach up in New York, in East Hampton. It was a huge success. We raised $8,800 in donations. So we appreciate everybody that was a part of that. I told the planning committee yesterday, I said, congratulations, job well done. Now let's get to work and put these resources in the right place where they need to go. Looking ahead to the future in terms of our speaker series, the next 2 dates that we have on the books, July 29th, we have Caroline Williams and Keela Strick. They are with the Fried Center for Advancement of Potential, and they're going to be talking about how they help the elderly community in the Harrisonburg, Virginia area. And then on August 26th, Fred Delp, who is the executive director of the National Alliance on Mental Illness, also known as NAMI, the Anne Arundel County, Maryland chapter, joining us to talk about what NAMI is working on. So those are the speaker series dates that take us through the summer. With that, appreciate everybody joining the call tonight on this windy, hot summer day. And have a great night.